Greetings and congratulations. American Shoulder and Elbow Surgeons honors and celebrates Asociacion Argentina de Hombro y Codo on its 30th anniversary. There is a long shared history between our societies, as Daniel Moya noted, and highlighted gatherings from some of our members here, Charlie Rockwood, smaller meetings. This is the Mayo Clinic course, to larger gatherings in the International Congress, and even socially. On this occasion, and on behalf of the society memberships, we have the following program planned to commemorate this milestone of 30 years. It's my privilege to present a brief history of the American Shoulder and Elbow Surgeons, and I'll touch on 3 areas. We've been very fortunate to have pioneers in North America. Of course, everything starts with Ernest Codman, the father of shoulder surgery, and his book. To quote Anthony De Palma, "The shoulder has laid down the foundation for all further study in this region." And we reprinted this in 1984, and then in 2019 on his 150th birthday. Harrison McLaughlin, a trauma surgeon, had great interest in the shoulder. He was also a colleague of here, a younger Charles Neer, shown in a picture at the New York Orthopedic Hospital. There are many contributors from Canada. One is Herbert Moseley, who brought together the first shoulder symposium in North America with an all-star faculty. Ralph Conrad focused on elbow, and the first elbow arthroplasty was implanted in 1974, and the Conrad prosthesis led to the Conrad-Mori implant. And of course, Charles Neer, which some feel is the father of modern shoulder surgery. And he, as much as anybody, had a significant impact on the international flavor of our field. Here is in a more casual picture, and the shadow is Charlie Rockwood taking that photo. And they had quite a friendship. In the early 80s, Rick Mattson, Alan Wild, and here shown Bob Cofield sent letters to people with a proven interest in the field. And the response from Canada and the United States was overwhelmingly positive. And an initial meeting to found a North American Shoulder Society was in January of 1982. The minutes of this meeting showed the name changed slightly. The first annual meeting was in New York in November of 1982, and they wisely added shoulder. Many logos were suggested, one of them adding American. And then in the article of incorporation, the full name American Shoulder and Elbow Surgeons is noted. So we were founded in 1982 with 26 original members, with Charles Neer as our first president. These are the founding members. Most are in this picture at the first meeting, including our new members and one international member, Hiro Fukuda. We've continued to have annual meetings. We then established our first open meeting, have done collaborations with the Academy and other societies, and along with our annual meeting, have had specialty meetings. This is the 10th meeting with the group who attended, and all the presidents are in the first row. This is 2007, those who attended the meeting. And this was our 25th anniversary, and many contributed to this book I was able to edit, which is also available on our website. Our membership has grown, and here's the distribution from which we have many volunteer members who contribute to the functions of our society. A second point is the Shoulder and Elbow Journal. This came together at the 4th International Congress to establish a journal on shoulder and elbow surgery, but not an American or an international journal, but one that was clearly global in intent. This was presented to our active members, we secured a publisher, and the first edition came out in 1992 with these 6 supporting organizations. The JSES has had healthy growth. You can see here even a COVID bump. And we now have a family journals, which can publish the valuable peer-reviewed research in our field. The ASES Foundation started as a small fund that our early members started, and it did well to support awards and grants. And 30 years later, under leadership of Rob Bell as president, the industry committee formed a subcommittee and had our first meeting in August of 2014. In just over 2 years, we had our first meeting of the Board of Trustees with a mission to foster scientific advances, enhance the study of shoulder and elbow care. These are our bylaws, and this foundation is able to meet these and address critical research needs, support the entry of young physicians into the field, promote and fund strategic educational initiatives, and educate the clinical and academic community as well as the public. We wouldn't have been able to achieve all that we have without a very strong ASES staff who recently moved to new offices with other specialty societies. And under the leadership of Ana Quintanilla, Executive Director, we hope to achieve even more. So what has the ASES accomplished? I'll use Bob Cofield's words. We have served as a forum of exchange of new ideas. We've developed educational programs in traditional formats as well as new online platforms. We fund research and awards. Our society has grown in structure to support all these initiatives. It has served as a great place for career development for our new leaders, and we've been able to start, maintain, and grow our international relationships. As Gandhi said, the future depends on what you do now. If that's the case, the future looks bright for both our organizations. Thank you.
Thank you very much, John. That was a wonderful presentation. I love talking to you and understanding how much you know and you have documented about the history of ASES. Our next speaker is Dr. Duralde, who is going to talk about what is new and controversial and exciting in shoulder instability in North America at ASES. Javier?
Thank you, Joaquin. It's my pleasure to participate in this forum to celebrate the 30th anniversary of the Argentine Shoulder and Elbow Society. So my topic today is what's new and exciting in shoulder instability at ASES. These are my disclosures, nothing that impacts this talk. So glenohumeral instability is typically caused by a combination of anatomic lesions, and a focus on one element of this, such as glenoid bone loss, is really insufficient to guide management. So I think our renewed understanding of the compounding effect of all these elements leading to instability and their impact on treatment is both old and new and exciting. We're rediscovering the lessons of our professors of how all these factors play together to cause instability and need to be addressed. What we found over the years is that arthroscopic Bankart is an important component of our instability repairs, but usually requires additional procedures to be effective. And an evolution in technique, specifically arthroscopic bone grafting to the glenoid, offers the most exciting area of progress in shoulder instability surgery today. So shoulder instability results from a highly variable spectrum of pathology, both in direction and degree, and contributing factors include capsular laxity, labral tears, and bony insufficiency, both on the glenoid and on the humeral head. And these lesions often occur in combination, and that's what makes it challenging to figure out how to take care of these patients and address all of these issues to obtain a stable shoulder. Pascal Boileau, in his landmark paper in 2007, evaluated 130 of his patients who underwent arthroscopic Bankart repair and found a very disappointing redislocation rate of almost 15%. And he evaluated the risk factors and created this ASES score, it's a 10-point scale, and found that if a patient had greater than 6 on the scale, that he had a 70% chance of failure from an arthroscopic Bankart repair, and he recommended arthroscopic Bankart only for cases that scored less than 3 on his scale. And if we look at the scale carefully, really there's 3 activity and lifestyle issues in terms of being young age and active in sports, but there's 3 additional pathologies which are identified: capsular laxity, humeral head bony defects, and glenoid bone defects, which contribute to failure of this operation. Castagna's group did a validation study of the ASES score and found very similar findings this past year. If we look at the literature in general, the failure rate of the arthroscopic Bankart repair varies between 10 and 35%, and the risk factors are fairly common among all the studies that we see, and again, activity level and other pathology. And this really is rain on the parade for the American enthusiasm for the Bankart repair, and makes us really take a step back and re-examine how we're dealing with these patients. So who is the ideal patient for a Bankart repair? Really, it's someone that has an isolated 90-degree anteroinferior labral tear, has an index dislocation, minimal laxity in the remaining capsule, minimal bone loss, older patient, perhaps female, and low demand. And we have to ask ourselves, does this patient actually exist? And is that who we're seeing in our office? And I know for me, it certainly is not. And we have to ask ourselves also, how common is the associated pathology we see in these patients, and how often does it impact our decision-making? So if we look at capsulolabral injuries, we know that capsular stretching occurs at the time of Bankart lesions. We know this from biomechanical studies by Dr. Biliani. We know that laxity increases the risk of instability. So patients who present with instability often have this as a pre-existing risk factor. And we also know that residual laxity after labral repair may affect the results. But we don't know exactly what the incidence and degree is of capsular laxity among the patients that we're treating surgically. Now, with glenoid labral tear patterns, we have a better idea. Our group looked at 280 sequential surgeries and found that only 17% of patients had an isolated Bankart lesion or anteroinferior glenoid labral tear. But if you looked at everyone who had an anteroinferior glenoid labral tear, 115 cases, or 41%, were in this group. But these consisted of patients who had extension of the tears either posteriorly or superiorly. So that we see that if a surgeon identifies a Bankart lesion at the time of surgery, in less than half of cases is that lesion isolated to that area. And more often than not, the surgeon needs to continue looking for additional pathology and treat it if he expects to get a good result from that instability repair. Well, what about bony pathology? Well, Hill-Sachs lesions occur between 60 and 90%, bipolar lesions about the same, and glenoid bone loss in up to 86% of patients who undergo surgery with greater than 25% bone loss and over 5%. It's very common. Now, the older literature told us, well, if you had glenoid bone loss of 20 to 25%, you could still treat that with a soft tissue procedure. But the newer literature is showing us that even less bone loss of the glenoid is associated with worse results of our surgery. And the newest literature shows that there are functional limitations in patients who are treated with an isolated soft tissue procedure, even with glenoid bone losses as small as 10%. So we know that capsular lesions are not rare. We know most patients have extensive labral tears, and we know that most patients who present with instability have some type of bony lesion, and the degree of bone injury and the tracking affects the results in our management of these patients. So isolated arthroscopic Bankart repair is rarely an adequate treatment for these patients, and we have to start thinking about what additional procedures can be added to this to make the surgery more successful. So these could include the imbrication of a patulous capsule, identification and repair of the entire extent of the labral tear, addressing Hill-Sachs lesions with a remplissage procedure, and addressing glenoid bone loss with an arthroscopic procedure. And this really is the new frontier for us, as there are very few surgeons in the world doing this procedure successfully and still working out the kinks. Well, how are these procedures working out? Well, Park did a study on 100 patients, did arthroscopic Bankart repair plus capsular imbrication, and he had somewhat mixed results: 8 redislocations, 18 patients with continued positive apprehension sign, and he found that the high-risk group for failure in this was women, elite athletes, and multiple dislocations. But I think that this diagnosis is hard to make, and I don't think we've done enough literature in this area to really figure out how capsular imbrication plays a role in our care. Now, extended labral repairs have been shown to work. Feng did a study on, reviewed 7 studies, 520 patients looking at slap bank cart repairs, and found that the results were equal to bank cart repairs as long as all the pathology is treated. These studies have been demonstrated, the results have been demonstrated by other studies, and Wall even showed that in 360-degree labral repairs, that as long as the entire labral lesion is repaired, the results can be good. Recently, McDonald looked at the addition of a remplissage procedure in patients who had glenoid bone loss less than 15% and had a Bankart lesion and a Hill-Sachs lesion, and found that the results were significantly better with the addition of the remplissage compared to an isolated Bankart repair. And he felt that this procedure demonstrates early promise. But what are the limits of the remplissage? Obviously, it can't be done for all extensive glenoid bone loss. Goivea's group, Hughes, and Arciera's group really find that somewhere between 10 and 15% glenoid bone loss is the limit at which bony procedures are preferable over arthroscopic soft tissue procedures. And this really is what's most exciting, is this new field of bone grafting to the glenoid. And so the pioneers in this have been Dr. Lafosse and Boileau with the arthroscopic Latarjet procedure. Several other authors in ASES have been working with other types of bone graft to try and create these bone grafting techniques. And this is still in the developmental phases, both in terms of instrumentation and fixation techniques, but it really offers a way in which all pathology can be treated arthroscopically. Moroder in his Neer award paper showed that iliac crest bone graft had equal results of the Latarjet procedure, and it may be that bone graft by itself without a Latarjet will be adequate. Unfortunately, the arthroscopic Latarjet has a significant learning curve. Instrumentation and fixation is still being worked out. Complication rates are not insignificant, but they are equal arthroscopic versus open. And the benefit of this procedure will be visualization and treatment of all pathology in a minimally invasive way, allowing a triple blocking technique. So our recommendations for the future are the same as the recommendations of the past. To correct instability, we want to restore anatomy. We want to clearly identify the pathology through advanced radiographic techniques and arthroscopic evaluation, and correct the pathology arthroscopically, both in the labrum, imbrication of the capsule, remplissage procedures for Hill-Sachs defects, and restoration of glenoid bony anatomy, which is a new frontier in arthroscopy. Thank you.
Thank you very much, Javier. That was a wonderful overview of how we deal with shoulder instability in North America at ASES. Our next speaker, Dr. Samer Hassan, is going to cover the topic of rotator cuff repair. Samer?
Thank you, Joaquin. So I've been charged with providing an update on the treatment of reparable and irreparable rotator cuff tears. And again, I'd like to start off by obviously recognizing that this is a wonderful occasion to celebrate the society on its 30th anniversary. I do have strong ties to Argentina, having married my wife from Quilmes, Mariana. We met over 30 years ago, and I've traveled throughout the wonderful country that is Argentina. Our next trip will just be in a couple of weeks. And I also know full well of the strong tradition of shoulder and elbow surgery, having presented there nearly 20 years ago and several times since then. So it's a great honor to be a part of this group. So I'll start with reparable tears. And the key here is to select the proper tear in the proper patient. We want to choose a patient who has no barriers to healing, with reasonable expectations and good social support. And despite that, we have to recognize that sometimes some of these tears do not heal or re-tear. With one large study out of Korea documenting a 24% re-tear rate, with risk factors including older age, larger tear size, retraction, fatty infiltrate. And again, the challenge is especially great for large and massive tears, and these frequently do not heal. We have to learn to recognize the tear and the muscle as well. So looking at our sagittal obliques, at the amount of muscle bulk, and looking at the amount of tendon length, because these are important considerations. We want to steer clear of situations when there is a lot of fatty infiltrate or fatty atrophic changes. And yet, we also know that mild to moderate glenohumeral arthritis in of itself is not a contraindication, with some recent work by Albert Lin showing that patients do just as well in the setting of irreparable tear with or without arthritis. We recognize tear geometry based on our MRI, but also arthroscopically, looking at our lateral portal to get a sense of the tear geometry and tear strategy or repair strategies. We do associated or adjunctive procedures based on careful preoperative exam. And then we have to place our suture anchors. And we've come a long way here with suture anchors over the 30 years and almost full circle. We started with single row repairs, anchors placed laterally, and then we went to double row repairs to improve our footprint contact. More recently, we've gone to linked double row or transosseous equivalent repairs, but caution has been raised over the potential to strangle the tendon, perhaps impeding perfusion. And we know when these fail, sometimes they fail medial to the repair and are very hard to revise. We also have to consider the cost of 2 rows of anchors. And still in the right patient, this is often very gratifying to bring the tendon out of length and repair it securely. More recently, there's been discussions of going back to single row, but placing the anchors more medially for less tension, recognizing that often when the tear occurs, there's a stump of degenerative tissue that often disappears over time or has to be removed. And you can take advantage of triple loaded anchors for more points of fixation and load sharing. A recent study by Gettleman and Steider out of SCOE showed greater than 90% healing by MRI. And this is one such patient of mine, again, showing a medial single row repair from posterior and again from lateral, not too worried about not filling or covering the entire footprint. And one other strategy that can be used, and they've discussed this as well in their work, is marrow venting. And you can also achieve the same role in trying to get marrow element egress that'll help with healing using fenestrated or hollow anchors. There's been a lot of craze over the use of patches, and this still has to be sorted out, the right type of patch, the right type of source, but this is a very hot topic with xenografts, allografts, and even synthetic options. And this is just a partial list of some of the augmentation devices that are available. So here's one such a situation where we use the biceps tendon at the time of revision surgery to extend the footprint coverage and maybe add some biology. And this has been described elsewhere. Rehab cadence. How do we rehab our patients after rotator cuff repair? Well, the pendulum is swung from one extreme to the other. Early motion, then delayed motion, and now back to early motion with a number of level 1 studies supporting early mobility in small to medium tears, and even one study suggesting that patients did better if we didn't put them in a sling after surgery at all. But this may not generalize to our larger or massive tears. Now, for irreparable tears, these are those that cannot be repaired primarily. They include some massive tears, but also smaller tears with severe tendon loss or contraction. And these are also tears that can be functionally irreparable, even if they're otherwise fixable because of atrophic muscle changes, fragile tendinous tissue, or in patients with a biologic impediment to healing. And so these are some of the strategies that are available for the functionally irreparable or truly irreparable tear. One can do a tuberoplasty to smooth the tuberosity to prevent abutment or impingement. I learned this from Rick Mattson over 20 years ago as the smooth and move procedure, and he did it open, but it can certainly be done arthroscopically. You can do a biceps tenotomy, and the important thing here is the move part to mobilize these patients right away. So here's one such patient who failed multimodal conservative treatment. She's an 80-year-old. At the time of surgery, her tendon could be fixable, but it's not likely to heal. And we simply did a tuberoplasty, and did a debridement and a chromioplasty and mobilized the patient right away, and she did very well. And this has been described with this study out of Korea showing improved outcomes maintained at 5 years. Partial rotator cuff repair is another strategy, and here one repairs what can be repaired, even if part of the footprint is uncovered. And this may be an indication for margin convergence to restore the rotator cuff cable and force couple, even if a portion of the footprint remains uncovered at the end. And this again has been studied with this paper from Derek Cuff, showing good outcomes at minimum 5 years. But again, these patients are immobilized, unlike a smooth and move, because you want to protect the repair. Superior capsule reconstruction is another procedure. This was pioneered by Mihara, working out of Japan, where reverse was not available for treating these patients until 2015. And his solution was to use tensor fasciolata autograft to reconstruct the deep layer of the rotator cuff by fixing it medially to the superior glenoid and laterally to the tuberosity to recenter the humeral head and to optimize deltoid biomechanics. And so, again, this can be repaired. In the United States, we'll use allograft because it's thinner and easier to deploy, and it can be done arthroscopically. And then after repairing it to the tuberosity, it's important to do a side-to-side repair to maintain the connectivity and improve the biomechanics. And yet it may be losing its luster because there are concerns that we're using the wrong material, allograft, it's too thin. MRI surveillance studies have documented high failure rates. particularly on the glenoid side. And some of these patients actually do well clinically, making us wonder, why do we put patients to such a lengthy recovery? The subacromial balloon spacer is another option. This is an arthroscopically inserted saline-filled biodegradable balloon that acts as a humeral head depressor. Although it's resorbed within 6 to 12 months, the results appear to be maintained for much longer. It's been in use in Europe for over a decade, but in the United States, an FDA clinical trial was initiated and the clearance for the device was obtained just over a year ago. And it's been in much wider spread use since then. This just shows a little animation on one of my early patients where the balloon is deployed through a lateral portal. It is filled with saline a little bit more initially to iron out any wrinkles, and then a prescribed amount is removed so you have the right amount in the balloon based on the size of that balloon, and then you check to make sure it doesn't migrate. And you can see on this immediate postoperative x-ray that you get recentering of that balloon, of that humeral head against the glenoid with the balloon. And again, the pivotal trial for the FDA was recently published. I was actually one of the sites here, and it was published in JSES. And this was with a control group of partial repair patients. And the study found that the balloon was non-inferior to partial repair with comparable outcomes maintained at out to 2 years and a faster recovery of range of motion and outcomes in the balloon group. And although for the study, rehab was standardized in both partial repair and balloon, we know that we can mobilize our balloon patients much faster, allowing for an earlier return to work and sport, and it burns no bridges because of the rapid degradation of the balloon over 6 to 12 months. Lower trapezial tendon transfer is pioneered by Bassem Hassan, working alongside Joaquin and others at the Mayo Clinic. And again, this is an attractive transfer tendon because the line of force closely replicates that of the posterior rotator cuff. You do need to employ allograft to lengthen the tendon, and this can be done arthroscopic assisted. This is one such patient of mine who failed an SCR with an external rotation lag. And then we see here, we do a transfer of the tendon. And the completed repair. So it's currently a hot topic in the United States with excellent support from biomechanical data and clinical results. There's a steep learning curve because it's unfamiliar terrain to work at the back of the shoulder, and a commitment to learning these techniques is clearly important. So in summary, 90% of the repairs are performed arthroscopically in the United States. You need to select your patients carefully. Consider a single row repair for chronic tears, but linked double row repairs have biomechanical advantages. The biggest challenge remains improving the biology of healing, especially for our larger tears. And finally, for irreparable tears, for lower demand patients, we can consider some of these options as long as they don't have pseudoparalysis, but in patients with pseudoparalysis or arthritis, really the only reliable option is reverse shoulder arthroplasty. And the high demand patient without arthritis, these tendon transfers are really quite attractive. So over time, the algorithm will likely be refined because we still need better comparative and longer term study for all of these different treatment options. Thank you.
Thank you very much, Asamra. That was a wonderful review of a very complex topic about the reparable and irreparable rotator cuff tear. So whenever you can stop sharing your screen, I will share mine. And my topic tonight is to discuss what is new and exciting about shoulder arthroplasty in the United States and ASES. And again, enhorabuena or congratulations for all the members of the Asociacion Argentina de Hombro y Codo on your 30th anniversary. As I was thinking about this topic, I think there are 5 areas that are now top trends in shoulder arthroplasty in our country. First, pain control and a trend for more and more outpatient shoulder arthroplasty. Second, the increasing use of reverse and a different understanding. Number 3, more and more use of shorter stems and stemless prosthesis. Number 4, a revolution on computer-assisted surgery. And finally, some advancements in the field of revision arthroplasty. So regarding pain control and outpatient shoulder arthroplasty, the drivers initially were a combination of this concern about the opioid epidemic. There was a time where opioids were one of the main reasons for death, actually, in some areas in North America. And this desire to provide patients with a way to get home right after arthroplasty. And that brought over a number of things, including multimodal analgesia, the use of blocks, that are longer lasting and surgical site injections. And the bottom line is that multiple studies have proven, including ours, that all these techniques are very, very effective. So when I was a fellow at Mayo Clinic, I remember patients suffering for 2 or 3 days after shoulder surgery. Now you can see them eating lunch and going home in a few hours after having either a calf repair or an arthroplasty. And that is married to some extent to a huge emphasis on doing more and more arthroplasty of the shoulder as an outpatient procedure. And by this, I mean same-day discharge, meaning the patient walks in the hospital in the morning, has the operation, and goes home in the afternoon. The drivers, I think, are a combined interest in finances, of course, because that has a benefit for the patient, but also the surgeon and the institution. And also, this was pioneered prior to us by hip and knee surgeons. But the big catalyst was COVID. When COVID hit North America, I suppose like as in Argentina, there was difficulty with inpatient surgery in general. So that really drove the need to do more and more outpatient arthroplasty, and this is going to remain. What makes it possible, I think, is patient selection, patient education, pain management, and surgical efficiency. And we did a study recently in our institution that showed that we implement a strategy to optimize how we manage these patients through their day. We can increase same-day discharge substantially, and that translates into a combination of more surgical volume and cost savings that have translated in gaining up to 5 million a year. So currently, I tell my patients that in 2022, pretty soon 2023, this operation is an outpatient procedure, except in rare circumstances. Some people like to use algorithms, but I think it's actually easy to use a checklist where you identify the few people that have to stay in the hospital because they have nurse support, maybe they have chronic kidney failure, they need dialysis, if they have a lot of prescription drugs, if they use narcotics on a regular basis, when they are wheelchair bound, or if they have poor cardiovascular health. The second big bucket of trends that are hot and controversy include reverse arthroplasty, which has exploded. This is data from our registry at Mayo Clinic. The green line represents reverse arthroplasty. You can see how, as time has gone by, especially starting in 2009, reverse has taken over. And today in our practice, 70% of the arthroplasties we do are reverse arthroplasties. In terms of the design, it's interesting because now different philosophies are all converging, and most individuals agree that there is a sweet spot where you want to land your glenosphere, which has to be lateral by about 5 millimeters, posterior inferior, matching the native version with neutral inclination and the best possible seating. And in general, most surgeons, most companies recommend lateralizing on the glenoid. And the challenge is that if you lateralize on the glenoid a fair amount, it is more and more difficult to relocate the joint if you use a system on the humeral side that has a very thick bearing polyethylene. So the trend we see in North America now is that every implant that's coming out is emphasizing maximum lateralization and thinner polyethylenes, going to more of an inlay philosophy. The third bucket that is interesting about arthroplasty of the shoulder in North America is the interest in using stems that are shorter, and of course, in anatomic arthroplasty, stemless. This has been driven by marketing to some extent because companies are interested in selling these implants, but also an interest in bone preservation and the fact that you can easily adapt these components to deformity, but with potential advancements, there are also some potential problems. And the two main ones is that a short stem and stemless are very easy to malalign, and some of the short stems have led to very adverse bone reactions. For example, this is a patient I operated on in 2013. You can see a reasonable position of components. I want to call your attention to the amount of bone loss on the glenoid and the humeral side by 2021, where there is not only severe notching, but a complete absence of the greater tuberosity that led to pain and loss of active external rotation and revision surgery. So some of the things that were supposed to be advancement have actually led to some complications that were unforeseen. The same thing is true with malalignment. If you have a short stem or stemless, it's very easy to place it into too much varus or valgus. That may not matter tremendously in an anatomic arthroplasty. For reverse is actually important because if you're in varus, your polyethylene is now more vertical, you will have more dislocations. If you're in valgus, you're going to have more notching. However, I think it's fair to say that stemless and short stems are here to stay, and there are a number of studies in North America going on trying to approve through the FDA a stemless reverse shoulder arthroplasty. Another field that is exploding in North America is the field of computer assisted arthroplasty. And it has many, many different aspects, including the basics, like pure planning software, the use of implants that are matched to the patient, execution of surgery using PSI guides, navigation, or robotics, and then the whole field of AI that is helping us with both decision-making and outcome prediction. I think many of the surgeons in Argentina probably use some type of program where you can import your DICOM files and then understand the deformity in 3 dimensions and try to understand where do you place your implants to optimize range of motion, fear of impingement, and alignment in general. So that's very commonly done. And I think in Argentina, probably many surgeons are also using occasionally these patient-specific guides that will guarantee that whatever you plan is going to happen. But now there is an explosion of interest about patient-matched implants, meaning that you plan where you want your base plate to be, you hit a button in the computer, it generates a metallic envelope that has the shape and the thickness that will allow to replicate exactly the position of the component. And I think this is going to be revolutionary. And then there's all the field of VR and MR. VR, as many of you may know, is a technology where you're actually completely immersed as a user. So you don't see the real world, only the digital world. But this is used at ASES mostly for training. So for our residents and fellows, we can provide them a subscription where they can use these devices to practice in their home at night with controls how to do an operation. Whereas mixed reality is a completely different technology where the user can actually use at the same time his interaction with the real world and the virtual world. So there is these systems that several companies have where you can have holograms that you can float in the surgical field, and it will allow you to understand your plan and replicate it, and pretty soon leading to navigation. Of course, in hip and knee arthroplasty, robotic surgery is now very commonly used. In our hospital now, the majority of primary total knee arthroplasties are performed with robotic surgery by different companies. And I think for us, it's going to be very interesting to adopt in the future because we already do CT-based planning. It is our second nature. There is many robots already implanted, and a robot can use a burr as an effector tool, so that will actually make possible to do the operation through the interval. And finally, all the field of AI. If anyone is interested, I would recommend this book by Julia Pearl that really helps you understand what is AI truly. And there is already tools out there in the market that will allow you to upload a CT scan and predict if you should do anatomical reverse. They can do automatic planning for you, and there is one company that has a system to predict the outcomes after arthroplasty. And finally, revision arthroplasty is going to be a problem in the future. This is a paper we recently published with prediction of what will be the burden of revision arthroplasty is going to be increasingly dramatic in our practice. And the problem is that we still haven't figured out how to identify and treat PJI, and glenoid and humeral reconstructions are still in their infancy. When you have a patient with massive failure of the glenoid, initially we all jumped into the bandwagon of using a structural allograft from the iliac crest, which is something that Tom Norris, one of our former presidents, popularized. This is a very appealing technique, but of course it has a fair amount of morbidity and it takes a lot of time. Many have migrated to using distal clavicle, like Dr. Dolde mentioned, for instability. Can also be used for contained defects in shoulder arthroplasty. Is right there, very easy to harvest and use. But I think in the near future, we're going to see that all these bone grafting procedures are going to be replaced by metallic implants, like it's already happened with some companies and will happen in the near future, I think, across the board. And finally, on the humeral side, there is 3 things that are emerging. One is the use of distal fixation with implants that are very similar to the ones used in femoral reconstruction, tumor prosthesis, and APCs. And even though I myself like APCs a lot, the only reason to use APC is soft tissue reconstruction. So I think in the next few years, if we can find a way to repair soft tissues to metal, we may see that tumor prosthesis and distal fixation may actually replace allograft prosthetic composites. So in summary, the top 5 trends in arthroplasty in North America include pain control and a tremendous increase in the number of patients that go home same day after arthroplasty. Reverse has taken over Anatomic. 70% of our arthroplasties, as I said, are reversed today. And we have a different understanding. We're lateralizing on the glenoid and minimizing the polyethylene on the humeral side by using inlay designs. We're going to see more and more short stem and stemless. Beware of other reactions and malalignment, but if you get the alignment right and the geometry of the implant is correct, hopefully we'll have an improvement. We're going to see a lot of computer-assisted surgery coming our way, including AI, mixed reality, VR, and robots in the near future. And finally, we really have to get prepared because in the next 10 to 15 years, revision arthroplasty is going to be more and more common. So I would say that the shoulder has come a long way in the field of arthroplasty, but the best is yet to come. Thank you very much for listening and congratulations again. And I'd like to now transfer the podium to Dr. Sean O'Driscoll, my mentor and partner, who will talk about what is new and controversial and hot in elbow arthroplasty. Thank you, Sean.
Thank you, Joaquin. Let's see if I can share my screen there. Excellent. Well, hello, everyone. Good evening or good day. It's a great honor to be here with you. Joaquin asked me to speak about state of the art of elbow surgery in North America. And these are my disclosures. It's relevant because I'm a designer of the Tournier Latitude EV total elbow arthroplasty that's sold by Stryker. When I thought about the different aspects of state of the art, and we've heard some incredible talks this far, we went back and forth a bit, and I realized that probably the greatest area of difference between what's going on in North America and what's going on in Argentina relates to total elbow arthroplasty. We don't have time in 8 minutes to talk about all of the areas, so I thought I would spend really the time talking about state of the art of total elbow arthroplasty in North America right now. And as we think about arthroplasty, there are two broad options. One is an unlinked device used in some parts of the world. The other would be a linked device. But the question arises, why should we limit the choice? And should we have a linkable option? And that's really where we have been moving over the past about 23 years in North America. And I think it's where we will be in the future. The idea of linking the arthroplasty is to have a device that just has a simple component to be added, or not really having to require an extensive change, such as changing the stems. And so the device that we've worked on in a team now for these years is exactly that, a linkable arthroplasty. And the idea is that in the unlinked mode, we should be able to stabilize the components in the elbow for a period of time while healing is occurring. And this is done with a fiber wire type of suture through the component and then through the ulna, and linking the component temporarily until that healing occurs. This design team has been a great opportunity for us. It's been myself, Graham King from London, Ontario, and Ken Yamaguchi from St. Louis, Washington University. Ken was on the team for 20 years with us and recently stepped down from the team to serve in other capacities. But we've been together otherwise as a team for 23 years working on this. Our goals when we set out were to accomplish a decrease in bushing wear and a decrease in problems of instability with the unlinked prosthesis. We wanted it to be useful for all elbows, and so it had to be linkable. And we wanted it to be a high demand total elbow, so it'd be suitable for post-traumatic arthritis, which would be common, for example, in your country, and probably the commonest indication now. And in other words, we'd like to be able to bring it up to the standard for total knee and total shoulder arthroplasty. We also recognize the importance of the radial head, and in an elbow replacement, it would be essential in the long run that a radial head component would be part of the system in order to accomplish balance and therefore eliminate the eccentric stresses that occur in an unbalanced elbow, such as you see with just ulnohumeral replacement alone. So balance, we believe, does require a radial head. We've shown in some studies in the laboratory, in a publication by Inagaki from our laboratory, that this is in fact the case and that the radial head does balance it. Now, there are really two substantial changes that have occurred for us. And one I've mentioned is the idea of a linkable elbow that can be a high demand replacement. And the second is about the exposure. And there are two exposures that are being used currently. I'd like to share with you about the diamond pop-up approach because not everybody will be familiar with it. I think many of you will be familiar with the para-olecranon that we use for revisions. But in the diamond pop-up, we have 4 steps to it. And this is a little animation that Joaquin made for us. The first step is to incise the fascia and the tendon. This is an arm that is viewed with the hand at the top and the shoulder at the bottom. So we incise an a diamond shape, and then we separate the central cord from the underlying deep head or medial head of the triceps tendon. So after that separation, we then would divide that central cord, and that includes both the long head and a significant portion of the medial head. We suture the ends of it temporarily in order to prevent it from delaminating. And then we reflect that central cord off the deep head in order to get down to the level of the elbow. So that would be step 2, is that central cord incision and reflection. Step 3 is new to almost everybody, and that is to incise this triceps capsular complex, which is the name we've given to the insertion of the triceps onto the capsule, because it really forms a tendinous muscular capsular complex. And then the step 4 would be to release the ligaments from the ulna. And by releasing them from the ulna, we can pop up the elbow and get access to it in order to replace it. This is a completely different approach from releasing everything off the humerus, and it provides for tremendous stability compared to other approaches. We then reverse those steps, repairing the ligaments, repairing the triceps capsular complex, repairing the central cord, and then finally closing up the superficial diamond-shaped incision. And stability and repair of the triceps are really excellent with that. So that's been one of the most substantial changes that we've had in elbow arthroplasty. To give you an idea of where we've come from, this is just an overview of the development of linkable arthroplasty since June of 2001, when we implanted the first one. And we have a number of different aspects that we've gone through with first and second generation. And since November of 2011, we've had the EV components, and most recently in 2019, the EV radial head. But you can see that there have been changes to the ulnar stem, the cap, the spools, and revision stems, and so on. The big changes that occurred mostly occurred very early, changing from smooth stems that were tapered to notched stems, and then eventually to porous surface stems on the EV. And you can see that when we look at the ulnar stem revision rate, for the survival curve was very poor with the first generation, which we rapidly changed. And even second generation had a significant failure rate with it. The current EV stem that we've used now for 11 years has a greatly improved survivorship. We still have a problem with the cap, that we think. The cap had a very high failure rate early on. This is the part that links the two devices together, or the two components together, rather. The current cap still has the potential to disassemble, but we have not been seeing that with the recent design. And there's going to be a redesign of that cap. Pardon me, I said we haven't, I back up on that. I said we haven't seen that with the redesign. We expect to see that change with a redesign, which we're hoping will be available before too long. But that's still the limiting factor with it, I think. On the humeral side, the humeral stem was revised to a porous surface stem in 2011. The smooth stem had a high failure rate, as you see in this survivorship curve, in the double-digit range. Currently, we're seeing little failure of this textured stem. The humeral spool was changed very early on because of problems with the screw backing out. We've not seen problems with that since that was changed almost 20 years ago. The radial head is the most significant recent change. It was just 3 years ago that a substantial change was made. And in that regard, two components of this were changed. One was the addition of a porous surface to the stem because of loosening. And the second was the addition of a locking mechanism for the bipolar head. So it does not just snap on, which means it can snap off, but rather it locks in place once it's been snapped on with a specific locking mechanism. It's a little bit early to know whether or not that's going to have the success that we hope, but we anticipate that that'll be a significant improvement. So if we look at my own experience over this past 2 decades with this, you can see generation 1, 2, and then EV generation. We have a total of 255 components there. You can see the breakdown by revision and primary as well, about a 2-to-1 breakdown between primary and revisions. pardon me. The overall survival, if we look at the complete survivorship, regardless of which component was responsible for failure, we've seen improvements from the first to the second generation and again to the EV generation. The EV generation, I think mainly the survivorship had to do with problems with the radial component, which, as I mentioned, was changed most recently in 2019. And here we see overall 5-year survivorship as well. So have we accomplished our goals? Difficult to say, but I think it's reasonable to conclude that we have decreased bushing wear. I'll give you some data on that in a moment. We've decreased the instability, almost eliminated it, but not quite fully. We believe that this is now useful for all elbows as a linkable design, especially for the high demand patients, such as the post-traumatic arthritis cases. And that's why I thought it would be of special interest in Argentina, where you would have a great number of a very high prevalence, I think, of post-traumatic arthritis and non-unions that really do require a salvage to a total elbow. Here we see 255 elbows. We have in this series of mine, we have no revisions for wear or for problems caused by wear. And that's a dramatic change from what we had been using previously. In terms of instability or the requirement to link it and add a cap, out of 46 unlinked elbows that we have the 2-year follow-up on, and this was a while ago that we looked at these data, 2% rate of subluxation, no actual dislocations. So I think we're getting down to the range of a very acceptable level. So if we take a typical example, this would be a high demand patient, and you would see these types of patients regularly. This is a 33-year-old muscular male, heavy labor. He is a machinist. He has severe post-traumatic arthritis with disabling pain, able to be treated with an unlinked replacement. In this case, the radial head was not able to be replaced because we did not have the revision stem yet. Now we would be able to replace that radial head. But he has a very good prognosis with this as it is. So in summary, the state of the art of total elbow arthroplasty in North America, we think, is that we would use and prefer to use a linkable implant with a large surface area and a durable polyethylene lining. We need precise instrumentation, which we now have, and we believe we're at the stage where we do have this good option for patients with post-traumatic arthritis and osteoarthritis as well. Gracias. Thank you very much.
Thank you, Sean. That was a wonderful presentation on what we know now about elbow arthroplasty. Thanks mostly to you. So I want to close out by thanking all the speakers. Dr. Ticker, thank you for that great summary on the history of ASES, and then Javier for instability, summary on the rotator cuff, and then Sean for the elbow arthroplasty. I hope that the Argentinian members will enjoy this presentation, and we really are looking forward to more collaboration with the society. Again, congratulations for your 30th anniversary, and have a great time.